So fever. So let's talk real briefly now. Once again, I don't think that you guys have been with me. So if there's something, because some of this stuff does build on itself. So if there's something that you don't understand, put it in the chat or something, and we'll get to it. As a little bit of background for so that you guys understand where I'm coming from. I'm an emergency physician. I'm an EMS physician as well. I've been a medical director since 2000. I've been for some large services such as St. Charles County Ambulance District in Missouri, and Life Care here in Parker County in Texas, just outside of Fort Worth, but also some really small services. I'm currently the medical director for Shackleford County, which is between here and Abilene, and they run one truck 24 hours a day for the entire county, and then some private services as well. I am a former EMT and a paramedic. I started in this stuff back in 1981, so I've been around a little bit. Things have definitely changed a lot since I was a field medic. I've seen a lot of things that have changed, and a lot of the skills are much, much higher than they ever were when I was a paramedic. So, you know, feel free to ask any question. If I don't know the answer, I've got a lot of colleagues of mine that we can certainly try to get the answer from, but please ask questions. So, we're talking this evening about fever. So, what's the definition of a fever? According to grandmothers, anything above 98.6, and every one of them is a life threat. Okay. In actuality, though, medically, it's a temperature above 100.4, and most of the time, it's actually a good thing. So, let's talk a little bit about what a fever does. First off, it does kill disease producing organisms. It does produce some germ killing substances, and we'll talk about some of these things as we go along. Interleukin, especially, is a cytokine, and that actually helps with our immune response. Interleukin 1 is the most significant. And it also can help to, when we have these things that raise our set point, there's a group of chemicals that are known as pyrogens that can actually cause that to happen. And so understand that the hypothalamus is our thermostat in our brain. So we actually do things to conserve our heat and our calories as we try to increase our body temperature, because it's an energy draining process to run a fever. Now, older adults or even young children, especially under 3 months of age, they may not be able to develop a fever. And sometimes it can be really, really frightening almost when they have either no fever and obviously they're sick, or sometimes they're even hypothermic, so their temperature may drop. So these are not good things. So, what are the effects of a fever? Well, first off, you have to increase your oxygen need, and that's because of the higher respiratory rate and the heart rate. You also have to, it does enhance your immune system, and it has higher activity with the white cells, and also it activates these cells called T cells, and these are part of our immune system. It's not important that you understand those things necessarily, just understand that it enhances our immune system. And it also does inhibit microbacterial growth. I tell parents all the time, when we're doing cultures in the lab, in the hospital, whether it's blood cultures, throat cultures, urine cultures, they set those incubators at 37 degrees centigrade. That's 98.6 Fahrenheit. And they do that because we want to see what is growing in that person at that temperature, and that's where they tend to grow best. Whereas when we're sterilizing things, we actually put those into higher temperatures. That way, that helps to kill them. And I'll even go so far as to say, if you ever meet somebody that's a microbiology student, if you really want to tick them off, go and turn their incubator temperature up, even 1 degree, because it'll end up killing the things that they're trying to grow. So, do they want their child to be an incubator, growing a lot of these bacteria and viruses, or do they want them to be a sterilizer, killing them? And yes, I use that exact terminology. So, hypothalamic stimulation causes vasoconstriction. Okay, so they tend to have their skin get somewhat pale. They also develop this thing called piloerection, and what that means is that the hairs will actually start to stand up. So, you know, women that don't have a lot of hair on their arms and stuff, they may not necessarily notice it, but they'll notice that they get goosebumps. And that's because your body is trying to increase that layer of insulation. That way you minimize the heat loss. And then they begin to produce heat through shivering and other mechanisms such as thyroxine. Thyroxine is a thyroid hormone, and that will increase your metabolic rate in every manner. So that's how you actually develop a fever. So fever versus hypothermia, or hyperthermia, I should say. There is a difference between these two things. First off, a fever is the elevation of the thermoregulatory set point, and there's a couple of reasons why that can happen. Whereas hyperthermia is usually due to exogenous heat. So, in other words, the guy that's a roofer in the summertime in Texas, okay, he's up there, he's not drinking enough water, he's unable to lose enough heat, plus he's standing on a roof, which is usually hot to begin with, and under the sun, so there's more heat. So those are the sorts of things that produce hyperthermia. So would it also be from evaporation of sweat? I'm not sure what you mean by that, Laura. You can unmute.
It was when you were talking about the hair follicles standing up.
Oh, no, no.
No?
Yeah, actually understand that evaporation of sweat will actually cause the body temperature to go lower. So during this time where their fever is coming up, they don't sweat. It's when they begin to break the temperature that they start to sweat. That's part of how you lose the body heat. So another way of thinking about it, and it's a great question, it really is think about yourself when you've had the flu. And if you've ever had the flu, you know, you have these periods where you're chilled and you just can't get warm and you cover up in all of the blankets and everything. That is increasing that insulation. Okay. But as the fever breaks, all of a sudden you feel hot everywhere. You throw off all the covers, you're sweating. That is how you lose that body heat and bring that temperature back down. Okay. Is that
Yes, thank
Does
you.
that answer the question? Sure.
Mhm.
Okay. Good question. Okay. So now there is a difference between fever, hyperthermia, and there are fevers that can develop due to damage to the hypothalamus. Okay. So either from a traumatic injury to the brain or somebody that's had a stroke and they bled in that area. In those cases, their temperature can go dangerously high, and it's all due to the metabolism. So, you know, those are they're rare, thank goodness, but they do happen, and in those cases, those have to be treated differently. So, I've got a video here. I hope that it'll play. If not, I may go and see if we can get it to play. Tell you what, I'm going to see if I can get this to open in another window, because this guy, he's actually an excellent physician. His name is Anthony Caraco. So let me see if I can. And then we'll get him to play.
We're having a little difficulty hearing the video,
Hearing what?
hearing the YouTube video.
Okay. Well, I'll tell you what, let's do this then. We'll start back here at the beginning and we'll have some subtitles. Do you see the video?
Yes, yes.
Okay. So let me get back to the PowerPoint. So any questions about that, just so that you're aware, oh, hold on. Okay. So if you notice, he says a temperature of 40 to 41 centigrade. He's talking about a temperature of 104 to 105.8. That is very high. And most of our folks, our parents, would not approve of us not treating that. But I'm going to share with you some other stuff. This is not new information, is what I tell parents. One of the things that we're going to look at actually came about. It was originally copyrighted in 1994. That was before I finished my residency. But we're just now really getting to where we're trying to educate the parents about this. So I don't know if y'all saw that recently there was a notice that said that the normal body temperature is changing. And it's like, what? Christian, we're getting to that. So we'll kind of answer your question. That's a great question. We'll come to that in just a minute. So we came up with 98.6 because this Dr. Carl Wunderlich in the mid 1800s did axillary temperatures on 25,000 people. Understand that the thermometer that he was using took about a half an hour to check a temperature. So it was an early attempt to measure the temperature of patients. So, understand that number has been around for a long time and it's been based on axillary temperatures. And it also varies throughout the day. We know that. Women are warmer than men. Okay, so you women say that you're hot. We agree. And then young people are usually warmer than old people. That's why you see the old people all, huddled up in blankets and stuff. And lately, repeated studies have suggested that the normal temperature may be falling over time. So you see 20 studies showed an average oral temperature of 97.5. And they redid the study in 2017 and they got a similar result out of 35,000 measurements. So why would our temperature be drifting downwards? Well, first off, it lowers our metabolic rate. Okay. So higher body mass, better medical treatment, prevention, better overall health. Once again, you saw in that video, this is a huge expenditure of our body resources to maintain a higher temperature. So if the body doesn't need to do something, it usually makes it so that it doesn't. So one example of that is if I take somebody and I put them into a shoulder immobilizer and just leave them there and they don't move that, they'll actually get loss of range of motion. The body does things to try to stabilize things with as little effort as possible. So this is another example of that. So lower rates of infection and inflammation. So if you think about it, we don't see these things very often. Tuberculosis, yes, we see it, but not like it was in the early 1900s. Typhus, I've never seen a case of typhus. It's a flea-borne illness. And then syphilis, yes, that's still there, but it's not like it used to be. Chronic gingivitis, we have our dental care is so much better. So there's so many reasons to say, okay, well, we have fewer infections. So once again, it makes sense that the body's going to conserve its energy. And then better measurements. Perhaps it's just that half hour to measure a temperature that was axillary just really was not accurate. Maybe the thermometer was not accurate. So this next section, we're going to go through really pretty quickly. This is actually a handout, and I give patients, parents, this handout. And Christian, this is going to answer your question about where do we start to be concerned. So there's a lot of myths about fever, okay? And there was a Dr. Barton Schmidt, and he's going to be in one of the resource slides in a little bit as far as a reference material. But he wrote this as well, but he's the one that really coined the term fever phobia. And that was back in the 80s. So once again, this is taken from the American Academy of Pediatrics publications that Dr. Schmidt authored. And the copyright on this is 2000 to 2020, but the earliest copyright that I saw for the exact same stuff was 1994. So it's been out there a long time. So, myth, all fevers are bad. No, they're actually good. They turn on the immune system. Temperature over 104 is dangerous. No, actually, to cause brain damage, now I added the emphasis to this, only temperatures above 108 can cause brain damage. And you can't really do that due to an infection. It requires something else in children, like putting them in a hot car in the summertime. So, and once again, everything except what I said that emphasis was added, this is in that handout. Anyone can have a seizure triggered by fever. No, only 4% of children can have that. And seizures are harmful. No, but if they don't stop within 5 minutes, then they need to be evaluated. Okay, and so that's kind of the cutoff is 5 minutes. And these kids don't go on to have seizures at a higher rate than the rest of the population. Universally, children outgrow febrile seizures by the age of 6 years old. Okay, so if a kid is having a seizure after 6, that's not a febrile seizure, and that's a different animal and needs to be evaluated. And there's exactly what I just told you there. So all fevers do not need to be treated. And here's the answer to your question, Christian. They only need to be treated if they're causing discomfort. Okay. Now, and this is not in the handout, but there's some evidence, clinical evidence, that a temperature over 102 can cause these kids to hurt. And my theory is that it's because they're shivering so much that their muscles will start to hurt. So I tell parents, I've got two grandkids that live with me, 4 and 6. I do not own a thermometer. And the main reason that I don't even own a thermometer is I don't care what their temperature is. I'm going to treat my child, or in this case, my grandchild. I'm going to treat their comfort. So if they're uncomfortable, okay, baby, you know what? Here, have some of this medicine. We'll see if we can make you feel better. But my youngest child, and she's 12 now, she had multiple ear infections, and she would feel so hot that you're going, man, you got to have a temperature of 104 or so. And I still never checked her temperature, but she would be running around playing and happy as a lark. So why am I going to do something about that? Because it's going to actually help her. So they rarely go over 104 or 106. And once again, until you get to 108, it doesn't cause any damage. Now, this one is a big one. With treatment, the fever should come down to normal. No, actually, it usually only goes down a couple of degrees. And so, telling the parents what to expect a lot of times can help them through some of these things. So if you can't break a fever, is that serious? No, actually it doesn't, because sometimes they just don't respond. And if the fever comes down, expect that it's going to go up and down. That's normal. It happens with the medicine. It also happens if you don't treat the fever, that the fever is going to go up and down for a few days. Now, you guys don't know this, but September 23rd, I actually was diagnosed with COVID. I was having some chills and stuff, never checked a fever, never. Um, but I was having fever and chills. I wasn't taking anything except for the muscle aches that I was having, which goes along with viral type illnesses. So, it happens the same in adults as well. Expect that the fever is going to go up and down, and that's normal. And if the fever's high, it's serious? No, not necessarily. So once again, look at the patient, look at the child, especially because usually where we're getting calls for fever is in children. Okay. But look at them as a whole. And if there's something about the clinical picture that looks serious, treat it as serious. Okay. I see a lot of children in practice that they're sitting there laughing and smiling and usually watching a video on mom's cell phone and maybe eating some Cheerios. So, for the most part, these are not serious problems. And the exact number is not important. Once again, I don't own a thermometer. Now, in the ambulance, we're going to expect you to measure a temperature on these folks. Okay. But understand that bottom line is it normal or not normal? That's really what we want to know. And so they even address what's really a fever sort of thing. So over 100.4 is considered a fever. Okay. And so, summary, this is really an important thing that we need to actually try to pass along to parents. Okay. That is that the fever is actually a good thing. It is trying to help your child fight off an infection. Okay. So, Laura, your question is an excellent question. And I'll just tell you that first off, fever alone does not tell you anything. So you can't say, well, because you have a fever, you have COVID. Okay. But there is a correlation and a constellation of symptoms. So, from the standpoint of COVID, and where I'm at right now, I'm working in Texarkana most of the time when I'm working clinically. When I go in to see a patient, the questions that I ask, the questions that should be asked at triage are, have you had a fever or chills? Have you had a cough? Have you had shortness of breath? Have you had nausea and vomiting? Have you had diarrhea? Here's the really big clue, though, and that is, have you had a change in your sense of taste or smell? Now, I never had that with mine. but I know that we had a nurse practitioner that I work with that she did have it, and she said for like a month she couldn't taste anything. Um, One of our other doctors got diagnosed the same day I did. He never had any change in his taste. So, all of this is variable and it all has to be taken together. You can't just take one particular little part. And I know that we go into the hospitals or something and they scan our temperature and they're like, has anything changed? They're trying to elicit, are there other symptoms? Now, for us, we should know when we have those symptoms and we should be the ones to say, I've got this. We actually had a neurosurgeon or a thoracic surgeon that came into the ER a couple of months ago and said, guys, I think I've got COVID. Now, he was in the hospital at work when he developed his symptoms. And so, immediately, okay, come over here, sir. We're going to take care of you. But, obviously, a layperson, we don't expect them to know those symptoms. But I can't tell you how many times now I've asked those questions about smell and taste. And more than once, the patient has gone, why are you asking me that? That is such a random question, but I can't taste or smell anything. One of them said, I was having a hot dog the other day and I couldn't taste the mustard, you know, and it's like, okay, then you probably have this. So it's a constellation of symptoms that we have to ask about, but it's an excellent question. Keep in mind that fever is a very, very non-specific thing. So let's talk about when should a child, especially a child with fever, get an examination. If they're under 3 months of age, that one is an automatic. And here's why. First off, their muscles are not as developed. And so as a result of that, some of the signs and symptoms that we use to look for things like meningitis, they may not be there. They may not have enough muscle mass in their neck to give them a stiff neck. And at 3 months of age, they can't tell you where they hurt. So in those cases, those kids need to be evaluated. Um, Children with temperature that is difficult or unable to be aroused. So, the lethargic child, do not use that term lethargic. I'll tell you right now, we don't like that term because it has a legal connotation to it. So difficult or unable to be aroused is the way that we would like to hear that. Anytime that there's a rash, headache, stiff neck, irritability, or listlessness, we're thinking about meningitis, we're thinking about things such as Rocky Mountain spotted fever, those sort of things. Those have to be evaluated. And I throw this one in there. Anytime a parent says, I can't explain it, but something isn't right. Okay. I had one of these parents who, when I was a resident, I was working with an attending who, let's see, how do I say this tactfully? He was an ass. And mom said, listen, this is not my first child. This is my third child. And there is something not right about how my baby is breathing. And I'm looking at the kid and I'm going, well, it looks like your child has what's called periodic breathing. And that's a normal thing. And she goes, I know, but he's not doing it right now. And I'm like, well, he's doing periodic breathing. She goes, I know, but that's not what I brought him in for. But he's not doing it right now. And I can't really explain what it is. So I went to the attending and I said, yeah, here's the story. And something just isn't right. And she is not a new mom. And both of us kind of looked at each other and he stiffened up and he goes, then let's admit him. And I'm like, okay. So we admit the kid. So I guess it was 2 or 3 days later, I'm back at work again, same hospital, and we admit another pediatric patient. And the pediatric resident comes down and says, hey, you remember that kid that you admitted a couple of days ago? And I'm like, yeah. And said, it's a good catch. And I'm like, what? Said, that kid was having 60-second apneic episodes, and it was only, we didn't let it go past 60 seconds. The nurse could not be stopped. They had to go and arouse a kid. And I'm like, you're kidding. So I never did find out what the final diagnosis was. But once again, if a parent who knows their child, and I don't know if y'all are parents or not, but a parent will pick up on things before we ever will. And so if a parent ever tells you, I can't explain it, but something isn't right, or anything along that line, believe them. Just go ahead and at that point, just say, yes, ma'am. If it's dad, yes, sir. Let's get your kid to the hospital so that they can take a look. So, take those things serious. Now, can we make this a little confusing? This is from the Pennsylvania Medical Center. So they've got this thermometer here about, in response to your question, Christian, about when should you seek help. If you look at this, you're going, okay, you've got 5 different temperatures there that you're telling me to bring somebody in for. What do you want me to do with that? Well, better thing, and if you look at this, you're going to say, okay, you know what? The under 3 months of age, those, once again, we got that one. That's automatic. Now, really for the most part, the rest of this is kids that don't look good, okay? Because most children that are 2 years old or younger, if the fever lasts more than 48 hours, they're going to be seeking care anyway, and they're usually not going to be calling us. Children 102 to 102.2 for less than a year, once again, look at the child. My kid, I'm sure that when she was a year old, that she had temperatures that were over that. But once again, these are kids that generally are not that mobile. So, they don't have as much muscle activity to raise that temperature. So if they're that high, okay, you know what? Maybe we need to let somebody take a look at you. But for the most part, they're usually viral illnesses. But I don't mind seeing those kids. And then for adults, once again, over 48 hours, over 103. But really, the bottom line is, just look at the patient, because that's usually going to tell you so much more than just a number will. But that was more an example of, this is really kind of confusing here. Can we maybe simplify that a little bit? But let's pull all this stuff together. First off, fever is common. It's a normal physiologic response. It does turn on the immune system, both in kids and in adults. The fever itself can directly kill the pathogens. Fever is good. Let's not shoot the guy in the white hat just because we don't know for sure if he's good or bad. And if God gave it to us, can it be all bad? And hyperthermia is not a fever. So once again, you got to pay attention to the environment that they're in. And so, or if there's other brain pathology. So I got a lot of references here. Obviously, you're going to need to go back and take a look at this. And if there's anything that you want to look at, I would encourage you, especially that one that's about the middle of the screen there, statpearls.com. Statpearls.com is an excellent resource, not just for EMS, it's for medicine in general, but they have a lot of really good papers there. They have some papers that are actually pretty brief as far as they're summing up a lot of information, and they're very well written and well done. So, I would encourage you to look at Stat Pearls for a lot of things. And then there's some varied sources here, including NBC News. Avoiding fever phobia, treat the kid, not the number. So there's that. And then, so the next page, there's some even more. And on this page, the third one down is an excellent paper. I've actually printed that off and put that in the doctor's work area at several places that I work. And when nurses come to me and say, hey, we got a kid with a 101 temperature, what do you want to do? I'm like, why? They're like, what do you mean why? Because they got a temperature. I'm like, no. Is a child hurting? Is a child crying? Is there some, let's treat the kid, not the number. And they're like, huh? So I hand them that and say, here, take a look at this evidence. Okay. And then the next one there is one that I wasn't able to read all of it, but so that one, they actually went into Australian ERs and tried to educate the nurses about pediatric fever. So, there's a lot of information that's out there. And if you notice, most of this stuff is newer, except for the fever phobia. That one's Dr. Schmidt's, and that one's 1980. And that was actually in the American Journal of Diseases of Children. That's in JAMA, or American Medical Association, and American Academy of Pediatrics publication. So some really good information there. And, so in case y'all don't know, I encourage you to read. And when I say read more than the abstract. Read the whole article, especially if it's a research article. Read to learn about these things and to learn about the statistics and stuff. A couple of excellent websites and podcasts that you can learn this stuff from. Foam ED, which is free open access medicine. That's what FOAM stands for. And then ED is emergency department. The Skeptic's Guide to Emergency Medicine is an excellent podcast. It's an emergency physician out of Canada, Ken Milne. And actually, if you looked on the thing for the video for Dr. Anthony Crocco, that was actually posted by Dr. Milne. And he is super approachable. If you send him an email, he will respond, and he is a super nice guy. And then out of Texas, we have Rebel EM, which is out of the San Antonio Emergency Medicine Residency. Salim Raze is the lead there. And both the Skeptic's Guide and FOAM and Rebel EM, what they tend to do is they take a paper, usually a landmark paper, and they pick it apart. They will tell you what's good about it, what's bad about it, where they believe that maybe there were some errors made in either the statistics or the interpretation. And then they come down with their own clinical bottom line. They're easy to listen to. So I would encourage you to listen to some of those. So those are the resources. So do y'all have questions right now? If you do, feel free to unmute your microphone. But let's answer all your questions.
No questions. Super enlightening, and thank you that was very thorough.
Okay. Well, then let's talk about, and I try to always throw in at least one case so that we can kind of see the application of the information. And once again, it's okay to say, I don't know. It's okay to ask questions. And I know that you're going to have one question. We'll cover it when we get to it. Okay. So you're called to the home of a 44-year-old female. And by the way, this is a real case. It's July and the temperature outside is 105. Police were called for a welfare check due to psych issues. They found a suicide note. Pill bottles are laying next to her on the floor. Claritin and Zoloft. Claritin is a non-sedating antihistamine. Zoloft is an antidepressant, and they're empty. And it appears that they only had 1 month of tablets in them, and they were filled 27 days ago. So, you got that to deal with. When the police got there, they said that she had opened her windows on a 105-degree day, had turned her heat all the way up, and had all the hot water on. She is well developed and well nourished, is what that stands for, WDWN. Skin is dry and hot to the touch, and she is not answering questions. So, what questions do you have at this point? So, here are vitals. Heart rate's 140, respiration's 26, SpO2 is 98%, blood pressure is 100 over 64, end tidal is 18, and her axillary temp is 106. Yes, the hot and dry skin is actually one of the key findings there. So, I want you guys to try to figure out what her GCS is. So ask me questions. Yeah, our respiratory effort is definitely a concern. We'll come back to that in a second. Well, she's not answering questions, so you can't find out if she's oriented. So there's your GCS. She eye opens to pain. Her verbal is that she moans, and motor is that she withdraws from painful stimuli. So anyone want to throw out her GCS score? Seven, nine, it's an eight. So that's actually what it translates to, is a two, two, and a four. So continuing that case, if we need to go back, we will. Okay, spit and skid. Okay, I tell all the students, and I do this with residents where I'm at right now, we have family practice graduates that are doing an extra year in emergency medicine. And I try to go through this with them on most of their cases early on. Spit and skid. Spit is a 4-item, we call it a differential diagnosis. So possible diagnoses. S is a serious diagnosis. P is a probable. That's what you really think it is. I is an interesting case. We'll come back and expand on all these. And then a T is a treatable condition. So you can't repeat in any category. So you have to come up with at least 4 different differential diagnoses. If you ask an internal medicine person, they're going to come up with 10 to 12, depending on which mnemonic that they use, whether it's vitamin or vitamin TID, and then they may even come up with more than that. But for a serious thing, I want you to think about something that is a potential threat. Okay. Probable, once again, is what you think it is. Okay. Interesting. We've all heard the phrase before. Believe it or not, this actually translates even up to the northern areas like in Ohio. If you're out on the plains of West Texas and you hear hoofbeats over the horizon, think horses, not zebras, because you're most likely going to see horses running at you, not zebras. But you still have to consider a zebra every now and then, because otherwise you won't know what that black and white striped horse is when it runs past you. And then T is a treatable thing. So that can be minor, it can be serious, but once again, it needs to be 4 different things. And then the skid is sick or not sick. Okay. Make a declaration of that. Understand that all of this, and especially the skid part, is trying to get you to where you're doing some clinical decision making. And part of that is actually declaring, are they sick or are they not sick? Okay. And if they're sick, those people need a lot of intervention. Not sick, okay, they may need a ride or they may be able to stay at home. Okay. K is for killer diagnoses. Okay. So this includes those serious things, but I want you to list off everything that potentially could kill this patient. And especially the things that if we don't intervene in that situation would kill them. Okay. And then I is for intervention. So what do you want to do? This is where with those medical students and residents, I want them to tell me, okay, well, I'm going to start an IV, I'm going to draw blood, and I'm going to order these lab tests and do this x-ray and all of that. So I want to hear their plan for the patient. And then D is for disposition. Now, for us in EMS, that carries a little bit of a different connotation. Things are changing. That may include, we're going to leave this patient here, but we're going to have the community paramedicine program follow up with them. That actually, in some areas, is a reasonable thing to do. Okay. We also are talking about, do they need a specialty care facility? So do they need to go to a stroke center? Do they need to go to a cardiac cath facility? So, or in the case of a pediatric, do they need a pediatric hospital? Are they okay going to a general hospital? So those are the sort of decisions that I want you to start thinking about now. And if you develop this habit of, even when the tones drop, start thinking about spit and skid based on whatever information you get from dispatch, then when you get on scene, obviously you revise it. You start, okay, well, some of those things aren't there. So this is something that in the ER, I encourage people to do before they go and see a patient. Do it while they're in the room seeing the patient, and then come back and let's talk about it, and let's go through this list again. So for right now, since this is your first time and we're starting to run kind of late, I'm not going to have you go through all of these things. However, for this particular patient with the overdose, serious thing, an overdose. And I mean something that maybe you're not finding that she could have taken. Okay. Probable. I think probably she took an overdose, but it's not that serious, and she is now hyperthermic because of her surroundings. The interesting thing, well, could it be that she has a malignant neuroleptic syndrome? Okay, there are some psychiatric medications that can actually give you hyperthermia. Okay, that's a zebra. That's a big zebra. And then treatable is she's got a simple fever. Okay, now in this particular case, let me get you guys to tell me, do you think she's sick or not sick? You can put that in the chat. Okay. Yeah, she is definitely sick. Okay. Killer diagnosis. In this case, her hyperthermia. She could be developing a heat stroke. So that needs to be addressed. Other things, you have to address her hypotension, her tachycardia, and also her hyperventilation. So there's a lot of things that potentially need to be addressed with this patient. From the standpoint of interventions, we'll come to that in just a second. And disposition, she definitely needs to be at a hospital, but I don't think that she necessarily needs a specialty hospital. So, Laura, excellent question. She actually is potentially a dehydration, and respiratory alkalosis, you need a pH to really tell that. And that's not something that you're going to be able to get. But she definitely has the respiratory drive to put her that direction. But the problem is you don't know if it's compensatory or not. If it's compensating for a metabolic acidosis, then her pH could be normal. So there's a lot that goes into that. And we just really don't have the ability in most ambulances to tell you that sort of stuff. So based on the case that you were presented, what's the most appropriate intervention? Okay. So both of you go ahead and pick one. I try to make this as much like National Registry as possible. Of course, in that case, there wouldn't be an appropriate answer, would there? Yeah. In this case, IV normal saline is the appropriate treatment. Now, we're not going to go through that. Now, let me go back to this. That very first one there, dantrolene. This particular case, like I said, is an actual case. It actually was presented to me by phone when I was a resident and I was on toxicology service. And in that case, the ER was calling because they told me about this case, and this was in Columbus, Ohio. And they said, do we need to give her dantrolene? And I'm like, why? And they were like, well, she's hyperthermic. And I'm like, we decided no, she didn't need, because she was not looking like a true neuroleptic malignant syndrome. So, it's not something that you're going to be giving. But, if you had somebody that said that they were taking Haldol or some of these other really strong antipsychotic medications, it might be reasonable for you to, in your report, talk to them and say, they have these drugs there and their temperature is just going up and up, and we're giving fluids, and and actually ice bath and ice packs is not a bad idea, but your best answer is D, to put the normal saline in. So in those cases, it may be something for you to at least pique their interest and say, could it be due to the medication? So, once again, I want you guys to always look fantastic. And so if you're talking about certain things like that are going to pique somebody's curiosity, that's a good thing. And you're thinking about your patients. So once again, certain drug overdoses, you're probably not going to see those. And once again, aspirin is probably the biggest one. Okay, aspirin can cause you to have a hyperthermia, and that's due to its acidosis that it causes. Um, in these cases, in any potential overdose, my protocols say that you have to call and you have to talk to poison control. And if you don't know the number, it's an easy number. It's 800-222-1222. Anywhere in the country, it gets you to the regional poison center that is closest to you. And so, in those cases, I always want them to call poison control, talk to them, let them know about the situation. They're going to ask you a bunch of questions and you're going to go, why are you asking me the stupid stuff? But from a toxicology perspective, 80% of all calls, including from EMS, can be cared for at home. And in those cases, the poison center, and obviously this isn't one of them, but in those cases, the poison center is going to talk to the patient, the family, whoever's responsible for the patient, and they will tell them what to watch for. And then they call them back on a very regular basis for at least several hours to check and see how they're doing. They will also, if you call and say, I've got, this patient, here's what's going on, and we're going to be transporting to St. Elsewhere ER, they're going to contact that ER and they're going to give them some recommendations for treatment. So we have it happen on a very regular basis. Hey, we got this guy. They think that he took some extra hydrocodones or something. So you need to watch him for 6 hours on a monitor and check levels. And, so they tell us what we should do. And that's good. I'm a big fan of poison control. I tell folks a story. First off, when I was a resident, we had to do a quality improvement project. And the one that I did was, how often are we contacting a poison center? Because I knew that there were a lot of times that my attending would say, it's a Tylenol overdose. You don't need to call them for that. And, or something similar. And, I knew that by calling them, they get put into a national registry. That makes the registry more reliable. So the more cases that they have, the better information that people have. Now, a few years after I graduated from my residency, I was working in the St. Louis area after I'd gotten out of the Air Force, and they brought a patient to us that was a glyburide overdose. Glyburide is a diabetic medicine. It actually causes your pancreas to secrete insulin. And we saw it all the time there. And so there's no reason that I would call them about it. So I called up and I said, hey, I got one. I'm just calling you to be sure it's in the registry. Here's a patient's demographic information. They took this much glyburide. We've got them on a D10 drip and we're going to admit them and then cycle see them. And they were like, okay, and you're going to start octreotide, right? And I'm like, octreotide? Why would I start octreotide? That's for GI bleed. And the lady on the other end goes, I don't know. I've never seen this on there before. We get these calls all the time. I've never noticed that. Let me find out. And I said, okay, I'm not starting until we find something out. So we both went to work trying to find out what it was. And about the same time I found the reference, she calls me. She says there was a paper that was published 2 weeks ago on glyburide overdoses and giving octreotide. And what it does is it shuts down the pancreas so they don't secrete more insulin, so they don't get as high on their or as low on their blood sugar. And I'm like, I just found the same paper. 2 weeks. And it was already in what's called Poisondex. So once again, even the things that we know very well, sometimes that treatment changes. And you don't want to be the last one to change to the appropriate treatment. So even a simple Tylenol overdose, just give them a call. It's not going to hurt anything. It may take a little bit of your time, but in the long run, it's going to benefit you. And if something changes about the treatment, you'll know it. So, what questions? We're right a minute over now. This is the shortest one that I've done, by the way. Did we put you to sleep? Okay. Well, if we don't have any questions, then I think that we can get all you guys out of here, and we'll tell everyone good night. And if you have questions, feel free to contact Miss Dinsmore, and she can give me the question or whatever. I have no problem answering phone calls or questions by email. Just let me know. All right. So y'all have a good evening, and we'll talk to everyone soon.